Hey everyone, welcome to another episode of Antidotes. I am Christine, your host. This week, we are getting a little bit off of our typical civilian medicine path, and we are going to be talking to someone that was an Army medic, like I was, but very different in the fact that they actually did something with it, which I did not. So this week, we have Pete. Welcome, Pete.
Thank you.
So, Pete, I was in the reserves. You are in the reserves now, but you were active duty?
Yeah, I've kind of made the rounds a little bit. I was active duty, and then I transitioned to Mass National Guard, and then I transitioned, to nothing. I guess technically the IRR, and then I, fell for the recruiter spiel and ended up in the reserves, which is where I am right now.
I'm actually still in the IRR, and I get so many phone calls and emails, and they're like, "We need medics. Come on back in." I was like, "No. I'm gonna stick with this nurse practitioner."
That's a different response than I had. I was like, you know what? This is a great idea. Totally gonna do that. Yes, to 6 more years. Let's do this.
This sounds like a lot of fun. So, how long have you been in total?
I think I'm approaching 9 years. I think 9 years in a couple of weeks.
Well, at that point, you kind of should just stay in for the retirement.
I mean, that's what everyone tells me. Yeah.
Yeah. So, did you start out as a medic?
Yeah, I started off. I joined a little later in life. I had tried several times over a long time to get in. First, like straight out of high school, I had tried. I had some interest in the Air Force initially, and then it kind of evolved into the Army. I had some knee surgery. I had bilateral femoral osteotomies when I was 14, which is kind of something people don't generally like to take into the military.
Mm-hmm.
So that was kind of a big barrier for getting in. But I had done pretty well on all of my high school testing, so I kept getting phone calls, and I just kept trying and trying and trying. I think I had 4 or 5 tries before finally, when I was 28, they were like, you know what, let's get you a waiver. Let's see what's going on. And things were good. They let me in, and so I joined with the idea. I had always wanted to be a medic in the Army, and I had done a delayed enlistment because all throughout the process of going through the waiver and going to consults and seeing different physicians to get cleared for military service, that position was available. And then when I finally got to MEPS, that position wasn't available anymore. So I had to delay my enlistment only a few months up till March. And then I could finally actually go in as a whiskey.
When I signed up, they tried to make me do like the medic / LPN, like the extended one. And I was like, no, I don't want to do that. And I like walked out the door, and then they called me like an hour later, and they're like, "Oh, one slot just opened up." And it's like, funny how that works. Those recruiters, they try and be sneaky.
That's exactly what happened to me. They tried to, they offered me, and this is no joke, they offered me an airborne plumber position, which, especially now being in for a while, I know that you can't really offer an airborne position at MEPS.
Right.
But that's what they said. It's a plumber position with an airborne identifier. Do you want it? And I was like, well, no, I want to be a medic. And I also left MEPS. And I'm from Western New York. I'm from like the Buffalo, Niagara Falls area originally. So there's the Niagara Falls MEPS is where I was at. And it's a good 45-minute drive home. And I had like just pulled in my driveway before they called me, and they were like, "Hey, we found a 68 whiskey slot for you." I was like, "Okay, I guess I'll be there in another hour." So
I'll drive on back.
Yeah, drive on back.
For anyone that doesn't know, Army medics are classified under the designation 68 whiskey. That's your MOS, your military occupation specialty. So we keep calling them whiskeys. So when we say that, we mean Army medic for anyone not in the military.
Yeah, or I don't know if it had changed, but it used to be healthcare specialist, and then I heard it was combat medic again. But I'm not really entirely sure since they split off the MOSs.
Yeah, so when I went through, it was definitely healthcare specialist because
yeah, me too.
Because you couldn't have women with an MOS with the word combat in it, because women were not allowed in combat actually until 2016.
Mm-hmm.
And I actually just did an episode on General Anime Hayes with the Good Nurse, Bad Nurse podcast.
Mm-hmm.
And she was the first female general. And so a lot of the stuff she did kind of helped with the whole women getting into combat and stuff. Anyways.
And that's a different topic entirely that we can totally get into, because I know that especially amongst like Bravos and combat arms and whatnot, that, there's definitely some people that are split on the issue, but, being overseas, especially as a medical provider, that's totally something that's needed. It's like a large gap that we would have is trying to treat the female population and just having our hands tied because we just were not the right gender.
Yeah, so I just released the bonus episode for that Haley was talking about, where she did CPR on a female patient in Saudi Arabia, obviously a Muslim country,
Hmm.
and they were up in arms that male EMTs and paramedics were coming onto the campus and that they would see them and they weren't allowed there. So kind of the opposite of that. And I know that a lot of women want to do it. I'm not saying every woman can do it, but there certainly are women that can do it. I mean, I joined as a medic because I knew that if I was to get deployed, it would be the closest I could get to being, on the ground.
Yeah, and there's a lot of bullshit that goes around with that too, pardon my language. But because there are women there, like it's not like
Yeah.
oh, there are no women in combat. It's like we have cooks that are women. There were medics there. We had this weird rotation with National Guard engineer units on my COP where I was, and God, I think Texas. I think they came in, and they had a female medic who would have been. She didn't stay very long, but she would have been on mission with us. She would have been, walking the line with the infantry. She would have been in the clinic with us, dealing with mass cows, and everything that we were dealing with. So, like, what's the difference? Where's the line drawn? Like, you don't have the specific MOS. Like she's going to be there. Like let her train to be there. This doesn't make sense to me. And then you have the other side of the coin when it comes to our need for them. Like I had different patients who I wasn't able to treat because they were female and I was male. We had a husband and wife come in after stepping on an IED. The wife stepped on the IED and it was a bilateral amputation, and the husband just caught some shrapnel to the stomach, and he refused to let us treat his wife.
Mm.
So we weren't even allowed to put tourniquets on. So she came in with like cloth straps on her legs in a wheelbarrow, and he walked in, wouldn't let us treat her. And we had to direct our ANCOP, our Afghan police force, to drive her to Kandahar, which is a 4-hour drive away. Do you think that patient made it?
Yeah, of
I
course.
don't know. And at the same time, like I had to evac him out, based on his injuries. So it's a tricky thing, females in combat. People want to say one thing about it, but there's definitely a need.
Yeah, and I think the people that say that they shouldn't go, or that they don't belong, I don't know always that their opinions would be changed a lot of the time unless they worked directly with women in that role.
Yeah.
So I know there are definitely some women that have gone through ranger school and now they're getting integrated, and I hope they make a good impression for the rest of us.
Yeah, and and that's one of the things too is like you're kind of looking at like what's allowed now and how are those women performing, but I mean women have been there the entire time. Like look at their performance, like so like a good example was we had a female cook who we had taught some like basic CLS stuff to, and she was already CLS certified, but
Which is
um,
combat lifesaver.
yes, correct. We had kind of taught her some advanced skills, and it wasn't necessarily so she could go out and start treating the populace, but it was so that we could more effectively communicate to female local nationals coming in through her what was needed. And it's like the telephone game, like I talk to the female soldier on ground. She talks to the interpreter, who's a male, and that's fine. And he talks to the female local national. So it's so convoluted, like, but it's a cultural thing. It's something that they require, and they don't have any problem with the interpreter being male, but the person who they are interpreting must be female. So
I think American civilians don't understand that as a medical provider, you treat local nationals a lot. So explain that a little bit.
okay, so it varies, and I can only speak to my experience. So my unit, I was attached to an infantry battalion. They were a striker brigade combat team, but we were pretending to be light infantry. So we were in the Horn of Banjoy. We were at this little place called Talican, which I challenge anybody to find on a map.
And that's Afghanistan.
Afghanistan, yes, in the Panjwai district. So we go there. I would say we have maybe 350 soldiers on ground. We had our infantry unit. So our company, we had a contingent of ODA, which is Special Forces, and we had another National Guard engineer unit who was on the COP, and they would rotate in and out. Sometimes there wouldn't be anybody there. Sometimes there would be. We were specifically responsible for our infantry unit, but we kind of saw everybody. There was also some Air Force there. We had Air Force EOD, and there were Canadians.
The bomb guys.
The bomb guys, yeah, which is a different That's another story entirely that we'll get into. The bomb guys, and then we had some Canadians for a while. We took over for another U.S. Army unit, but there was a strong Canadian presence when we got there, and then
And they're actually integrated. Their women can serve in combat.
Oh yeah. Their women can serve in combat and do regularly and do a phenomenal job. And we would rely on their women who were there to handle the things that we needed to get done that we should have had our own females to do.
Getting shown up by Canada.
Yeah, right. So and and they're all and they do a lot of I think the unit that was there, the soldiers that were left over there's some security elements, but then there was psyops. I think was the big thing that was kind of left over from the Canadians. They would go out and a lot of their operations were with special forces, and they had their own ideas. We were ultimately fighting the coin fight, which was counterinsurgency. Basically going out into the population and doing whatever we could for them to make them not decide to be Taliban and fight us, essentially.
So, as part of that, sometimes you would have to treat the local civilians, Afghan nationals. Was it only after they had been engaged in combat with the U.S. Friendly forces, or was it part of bombings, or how would they become your patient?
Well, it varied, and our overall medical operations were a little fuzzy at the time. We initially went there with the idea that we would only be treating our forces, but the need was there to do more. And one of the funny things I noticed when I first got there, I was the first medic on ground for my unit to do the handoff with the NCO who was kind of left over. And the way the life cycle goes is we come in with wanting to like heal the hearts and minds and
Yeah.
do the job and and throw candy to the kids as we walk through the bazaar. And then the unit coming out has been through fighting season, has kind of been through the thick of it, and they're kind of just done. So they're a little bit jaded. So they didn't see a lot. They started off seeing a lot of locals, and then they kind of cut it back. And then when we first got there, we weren't really sure what we were allowed to do, but we knew that we were doing the coin fight. So we would walk from Calais to Calais or village to village and do our key leader engagements. And then whatever medic was there was, the medical package. And we would do a little village medicine, which was really kind of strange. But we would offer, what we could as far as medicine was concerned. You'd see a lot of old injuries that people wanted you to kind of wave a magic wand at and make better. That obviously you can't, but you sort of do what you can, or almost even make a show of it to let them know that number one, you care, that you want to do what you can, and then number two, do actually what you can to make them feel a little bit more comfortable. One good example was we would see. I remember going to one village, and they set up, they started talking about what they're talking about, and usually they would be discussing the crops in the area and trying to get them from talk them out of growing marijuana and poppy. And I would just kind of sit in the area and wait for people to come, and I would get kids who had like broken their arm and it was never like properly set, and they had like lost some kind of circulation, and you can visually see the difference in coloration. But like at that point, what do you do? When you start kind of talking to them, they're like, oh, I broke my arm 2 years ago, and yada yada yada.
Yeah.
You're like, okay, well, what can I do for this kid? Well, I can't do anything to fix his problem, but he has like this splint setup that's like fiberglass insulation wrapped in like a 5K t-shirt that they're splinted with something. Like, I can probably do something better with this. So you check their mobility, you run them through an exam and do what you can for them. Is he in pain? Well, not anymore. Did he lose mobility? Yes, he lost mobility. He uses the brace as support. Well, yeah, okay, we can do something better for that. So you give him something better for that. And you kind of just build that relationship just solely based on, them gaining your trust for you actually, kind of giving a damn.
Yeah.
So, that being said, we saw the local population. I keep getting sidetracked. I'm sorry.
No, that's okay.
We saw the local population to that regard. So I would walk out into, and I can't say one of the biggest things that I try to push when I talk about my time overseas is that like being a combat medic is a team sport. Like, it's so much a team sport. There is no way that you can be the sole medic. I had done an interview for a book a while back, and it was kind of edited to make it sound like I was like the lone medical provider, like wandering Afghanistan. And
With like 700 tourniquets, throwing them at everybody.
essentially, like, yeah, like I had this like gigantic aid bag and I was essentially Dr. Quinn, medicine
Yeah.
woman. So that's not the case. Like there's a PA there. He wasn't there initially. He got there eventually. Each platoon has a medic. One platoon had two medics. They actually had an outpost a little further away from the main outpost. And then we actually were assigned, thankfully, two additional clinical medics who just kind of hung out in the clinic. We had a treatment NCO and then another specialist. So we were really plussed up with medical personnel, and we were able to rotate our medics on patrols and stuff like that. I was with third platoon when I deployed. I was actually the fourth platoon medic, but the medic who was scheduled to deploy was having a child, so he kind of hung back. Which I gave him a lot of crap about, but now actually having a child of my own, I just never, I could never do. So.
Yeah.
So we were really plussed up on medics. So we had the personnel to run clinic, So we did regularly, and it took a lot of time. We first started out with having a small clinical package right inside one of the gates, our rear gate, which was we shared a south wall with the bazaar.
So you keep saying COP, just for anyone that doesn't know, outpost.
Yeah, it's our outpost. It's a company level outpost, and like I said, we were a company that was there, and we shared it with a very small group of special forces guys, and they sort of ran the wall. So they would bring people to us. Special forces has a different configuration. They have 18 deltas who are paramedic.
Special medics.
Yeah, they're paramedic level, but they're not always readily available because they carry more than one responsibility for the unit or for their team. So, we would kind of set up in advance sort of who we would see and who they would see. And we actually had the higher level care provider. We had the PA.
Mm-hmm.
So any clinical concerns that came through to our COP, our outpost, we ran through our PA. So we actually had a pretty good setup where initially in that rear gate, we had this like a small clinical package, like a walk bag that we had kind of plussed up with clinical supplies just to do exams. And, if we thought it was something that the provider would want to see, we try to talk them into coming into the COP and seeing the American doctor, and that was kind of the biggest fight, was like the local population knew they needed medical care. Like that wasn't any question, but they were terrified. It was either, be it the Taliban would find out that they were coming to the Americans for help. We would have women bring children who were terrified that their husbands would find out that they brought their children, for help. And that was another big barrier that we kind of encountered as well. But eventually you get to the point in your life cycle of deployment where they start to kind of trust you, and they kind of get a feel for when the Taliban are watching and when they're not, when they can actually come to the COP and when they shouldn't. So we would see that. We would see like these big surges of people coming in to be seen, like clinical cases, like early in the morning, and then after like dinner chow. It was always like before breakfast chow, after dinner chow, we'd get something. And then initially when it came to trauma patients, they wouldn't bring them to us. If they brought them to us, it would be like very, very late in the injury, and essentially there's nothing we could do. And then eventually they started trusting us more, and they would come closer and closer to the point of injury. But
was there a Afghan hospital, Afghan clinic at all in the villages or anywhere near you guys?
No, the closest Afghan actual medical facility was in Kandahar, at least to my knowledge.
And that's 4 hours away.
That's 4 hours away.
By car, or how were they getting there?
By vehicle, however you travel. But by bird, I don't remember how far it was by bird exactly.
Okay.
But there was a pharmacist, and you can't see me, but I'm using air quotes. There's a pharmacist in the bazaar who was somebody who just peddled meds essentially. And they're Afghan meds. So it's meds that we were like, what the hell is this?
Yeah.
And they weren't trained in any way to use these meds. And one of the prime examples of this that I found when I was overseas, it was still pretty early in my deployment, and we were on a foot patrol, and we were basically walking out to this area they called the schoolhouse, which was this schoolhouse that they had built. It was this piece of land. I think Special Forces had put it together. They built a school for the locals that they wanted kids to go to, get an education. They thought education was kind of the way past what they were encountering with the Taliban. And the Taliban put out that if anybody went to that school, they would kill their families. So it just kind of became an Afghan police force checkpoint. But we call it the schoolhouse checkpoint. So we walked out to the schoolhouse checkpoint. Our intention was to kind of stay overnight, kind of, show the police force that we were, there with them and whatnot. And while we were out there, there was a couple of guys making naan in the dirt,
Mm-hmm.
for us, like essentially like almost with their feet. It was an interesting display. But their commander came up and they're like, "Oh, doctore," which is was what they called the medics. Everyone was a doctor if you knew anything about medicine.
Yeah.
He was telling me that he was having problems when he peed, and I was like, "Oh, great, okay." It was like, "What's the problem?" He's like, "It's a very strange color." And I was like, "Well, could you describe the color? Have you taken a sample? Can you describe the color?" And he was like, "Yes, it's very I can't remember. I think he said vibrant. It's a very vibrant color." And I'm like thinking like, "Oh, that's such a strange way to describe it." And I was like, "Well, have you changed your diet? Have you taken anything new recently?" And he's like, "Yes, I just got pills." I don't remember what he was being treated for either.
Oh,
He
I
was
wonder.
he was having back pain or something common, but nothing too crazy. He was having some kind of pain, and he went to the pharmacist in the bazaar, and he said he gave him pills and told him to take them 3 times a day, and he would feel better. And I was like, "Well, do you know what they are?" And he said, "No, I don't." I was like, "Well, do you have them? Can I see them?" He's like, "Sure, hold on." And he went away, and he came back, like 15 minutes later, and he had this tube, and I look at it. And there's English on the tube. It's a lot of other writing, but there's English on the tube. And they're 1-a-day vitamins.
Oh, it's like B12 or something.
Yeah, it's a
Yeah.
multivitamin. It's a 1-a-day vitamin that he's taken 3 times a day for
Yeah.
Lord knows how long since he's
Oh
had
God.
these, and he's
Yeah.
noticed that his urine is vibrant. So, I mean, easy fix, obviously, but like that's the sort of
Yeah.
thing is like they go to the pharmacist for a problem. He kind of gives them whatever the hell he has on hand and tells them that's what's going to fix
Then
it.
kidney failure.
Yeah, and then so no real medical facility to speak of. We would occasionally find drugs that were like Tylenol and stuff like that. I never would know what people actually had it for. Talking to the local national population about their clinical needs is always a little bit tricky,
Yeah, I can imagine.
just because of how they identify symptoms and whatnot. They always like use hand signals that don't always make sense. We'd always have the joke where they would like get their hand and make kind of like a pulsating hand motion on their arm, and we would think it was supposed to be to signify pain, but it was really like them pointing to their arm, and I'd be like, "Oh, it's your arm in pain?" He's like, "No, I have a thing here."
Oh.
Always the way that they sort of describe their symptoms weren't like totally consistent, I guess.
Yeah, you think that certain things translate culturally, but they really don't.
No.
So you've been interviewed a lot about your deployment. You had some pretty notable things happen. Do you want to talk about any of those?
Yeah, we can talk about a few of those. I'm usually pretty open about things that have happened over there, just because I do think they're clinically interesting, and they're not, especially like being sort of into civilian medicine, even though I don't work clinically anymore. They're just not things that I have noticed people kind of experience. And even being a military medic, dealing with that situation is totally different than how it would be dealt with here.
Why don't you tell people what you do a little bit in the civilian world
All
to
right.
start off, I guess?
Sure. So I work in a pediatric hospital, and I started off when I got off of active duty. I started going to school here in Boston, and I took a CA position, a clinical assistant, which is essentially like a nursing assistant position.
Mm-hmm.
And I was working in cardiology, and it was fascinating. I love cardiology.
Especially pediatric cardiology.
Yeah, and I had done ACLS, and I was an ACLS instructor before that, but like the whole
I renewed mine today.
oh, nice. Well, congratulations.
Oh, that's terrible.
But like even having done that, like the things that you encounter in pediatric cardiology in like a top hospital are like kind of insane. You just don't expect that to be a thing, and they were completely different experiences than what I experienced overseas. And
Yeah.
I would find that nursing would be like very interested in what I had experienced there, and then I was very interested in what they were experiencing here.
Yeah, you get a lot of like trauma and like a traumatic arrest, or an adult who has had like way too many cheeseburgers and they have a cardiac arrest because of that, and they need
Yeah.
stents. But kids, you get things like tetralogy of Fallot and
Mm-hmm.
patent ductus arteriosus and
Yeah.
all these congenital things that you never see. Actually, a couple of weeks ago, I had a patient come in who was in her 50s, and she goes, "Oh, I had a patent ductus arteriosus for PDA, which is like it's a hole in your heart, and they found it 2 years ago." And I was like, "What? How are you walking around with that?" She's like, "I don't know." She was from India, and yeah, my mind was blown. I thought it was very cool. She didn't think that.
She did not. She did not find it cool.
Anyways,
It's very interesting though, and you're right, because a lot of that stuff is found. Even when it's found late, it's like when they're teenagers playing sports. Like
yeah,
things kind of come out when they start being a little more active. So that is pretty
right.
insane. But you're right, like that. There's a lot of crazy cardiology stuff that you encounter that you don't It's just stuff that you don't see in the population that you're exposed to in the military. Even when you're not, you're working in garrison, we're still functioning, medically. We're still operating clinics and, doing sick call and then seeing patients, but it's a generally healthy population. If you have anything, you might have like a murmur, like an undiagnosed murmur,
Yeah.
like it's nothing too crazy. So then to come into the civilian side and see all this stuff, it's pretty crazy.
I was talking about that with Angela, who was in one of the earlier episodes, because she's a medic in the reserves too. And, obviously the reserves get shit on a lot.
Yeah, naturally.
And for the most part, rightfully so. But when it comes to the medical providers, when you have a medical reserve unit, if the medical providers are working in the civilian world actively in their job, it's a little bit different because you see so many really, really sick people that you wouldn't necessarily see in a healthy population of soldiers and their family. So there's some benefit to that, having reserve soldiers for those jobs.
Yeah, I think there's a tremendous benefit, and I definitely have seen that over my career in the military, which kind of gets to like launches me into a different little story. But
Sure.
I had a few different. I never answered your last question on it.
That's okay.
I promise we'll get back to it. I had a few PAs when I was overseas. So when I first came to my unit, I got there in October and we deployed April. I think the beginning of April, end of March, beginning of April, something like that. So this PA was an E6 or E7 and then did the IPAP program. So he did the Army PA program.
Mhm.
Then he was a PA. So his experience had been pretty much military. We deployed and we had a mass kill event that a secondary IED was initiated after the medical package was on ground to respond, and our PA went down. He was okay ultimately. It was mostly MTBI, and he did have a kind of a rough road forward from there, but he survived and he's doing well now.
Yeah.
But we had a new PA on ground by the end of the day. We evac 16 people in the field that day. Came home, changed out of our uniform, put on PTs, came back to the clinic and started running MACE exams to people who weren't sent out.
Which is the concussion exam.
Yes. And I wish I could tell you what it stood for now. I don't remember.
Military acute concussion exam?
Sure. Let's go with that. That sounds perfect.
I don't know, but that was creative if that's not correct.
Like I have a computer in front of me. I could probably Google this first. Yeah. So we're running all these MACE exams to these other soldiers who are on ground. And a few of them needed to be sent out too. But while we're doing this, another PA walks in and we're like, "Hey, who are you?" And he's like, "Oh, I'm so and so. I'm your new PA." And we're like, "Are you kidding me? Like we just sent our old PA away like a couple of hours ago." And kind of the point I'm getting at was that our old PA was very much military focused.
Right.
He did a lot of clinical things in garrison as far as our sick calls were concerned. He was a phenomenal educator as well. He pretty much he trusted his NCOs to do the training that their soldiers needed to get into that clinic, to run the exams, to sort of guess at a diagnosis and a treatment, and then sort of let them present to the PA, and he'd be like yes or no, or he gave us a lot of leeway. Like we could do a lot under him, and that was phenomenal. It was a great learning experience, and he would correct us when we were wrong, and he would teach classes in between. He was great. My experience with him, though, started in October, and we deployed in March or April. So my experience was solely based on training up for trauma. We did a lot of that. We talked about hypothetical traumas and that sort of thing. Ideas that he had that we would probably encounter during deployment. He had deployed previous. So now this new PA who was on ground was from the hospital. I'm not entirely sure what his position was before that, but he was very, very clinical and not very trauma oriented, and he knew it, and he was very open about it. And he was like, I'm looking forward to learning from you guys, and this, that, and the other thing. And we had a few trauma events where the differences became very apparent, and he saw the differences, and he eventually was like, hey, I'm going to take a back seat on these traumas, and I'm just going to be one of you guys. So our senior line medic kind of took the lead at the table and started, doing his thing, and then actually having the PA get down and sort of get that experience that the 68 whiskeys the medics were doing, like learning how to control bleeds and kind of understanding, the algorithm that we were running. So that was great.
Yeah, it's very different than being a provider myself. You don't learn trauma management like you do in 68 whiskey school. And if you haven't had that experience as a provider, you're going to be in over your head. I mean, you can obviously learn it. You're very educated. You can pick it up, but if you specialize in trauma like the whiskeys do, then if you don't specialize in it, you need to learn, and it's
Yeah.
hard. It's a very different animal than doing physicals and doing a cardiology workup or something else.
Yeah, and there's something to be said about like working in a hospital on a base and then deploying to Afghanistan, and now you're essentially in like a wooden shack performing medicine, and trying to manage a trauma, and you don't have to worry about the same things necessarily. And one of the big kudos I always give to this provider is that he had the self-awareness to be like, all right, I need to change the way I do things, and these
Yeah.
guys can help me do that. So he was really very much about like, I'm just another set of hands, tell me what to do. And he learned that way, and he was a phenomenal provider, and we had so much respect for him. But one of the great things about those differences between having a clinician come in and kind of take the reins and not have that trauma experience is that we had all this great clinical knowledge at our disposal. When it came to the other side of our job, having local nationals come in or having
Mhm.
Joe's come in with back pain, and
Yeah.
all these different things that would happen, learning how to write notes, write better notes, or having our assessments inform our notes, and memorizing notes help you inform your assessment, and that sort of thing. So there's a really great kind of juxtaposition between the two different types of providers, which was kind of interesting. And I always sort of like kind of cherished that experience, having these two different people.
Yeah, that's awesome. I think everyone should spend time pre-hospitally, maybe not in a war zone. Although, if you want to, I think that's cool too. I would love
Yeah,
to do it.
definitely.
But you should go pre-hospitally because it's kind of like the Wild West. And then you should also spend time clinically, in a hospital. You really need to understand how medicine is practiced on both sides to be able to adapt, because sometimes things go to hell in the clinic too, and you need to adapt. And then sometimes pre-hospitally things are very complicated and medical, and you need a lot of that cerebral processing of it too. So.
Yeah, and I think it kind of goes for like some of the judging as well. You get a patient onto your table. Even in the war zone, you had like a whiskey out, out in the field, and they like messed up an IO.
Mm-hmm.
And you're like, oh, this isn't actually giving the patient any fluids. Like, you learn not to judge because you realize you were also probably dodging enemy fire at the time. And
Yeah, that's a pretty good excuse.
yeah, I think so. You still
Yeah.
you should still get your IOs. If you're going for it, you should still make sure
Yeah.
it's in. But the things happen. Different things happen. So, kind of getting back to your previous question about some of the other things that kind of came up. There are a few things that were kind of like the the bigger notes in my brain of things that had happened as far as traumas were concerned. And I think one of the funny things I kind of take away, not funny, haha, obviously, is that a lot of the local national traumas kind of blur, they kind of blend together with a few exceptions, not because they're local national, but because they were so similar.
Sure.
We had a lot of, once fighting season kind of picked up, you take a lot of enemy fire, but it's all outside of like 800 meters. It's nothing you're super concerned about, with a few exceptions, but a lot of it has to do with either covering or protecting themselves against us reacting to them and placing IEDs. So there's a lot of IEDs, improvised explosive devices, that they put in the area,
Mhm.
and we had certain measures to sort of detect these things. The first measure was a Valen, which is a type of mine detector / metal detector that somebody carries in a foot patrol,
Mhm.
and that you sweep like you're looking for coins on the beach, but you're looking for a metal signature. And when you find something, you kind of prod at it and see what you find, and see if you can find a plate or whatever. So we had a lot of that going on in the area. The other measure we had was a blimp that had a very expensive camera attached to it that could see in the 360 and zoom in and zoom out and have different camera filters and stuff on it. It's called the PGIS. And that had civilian contractors at it 24/7. And their only job was to watch these screens and look for people in placing or initiating IEDs. So that kind of leads me to my first story, which is one of the only things I can actually find on the internet nowadays. But there's this PGIS footage that I've run across of, they're sweeping the area looking for people initiating IEDs or implanting IEDs, and they come across this young child, like maybe 6, 7,
Mhm.
something to that effect. And he's walking across like a very low bridge, or short bridge, I should say. And he, at the very end of the bridge, he kind of stops, kind of looks both ways, and then kind of darts off to the side of the bridge, kind of over to like where the wadi would go underneath it. At this point in time, what, all the wadis are dried up. It's all the river beds are dried up. So everything is just dirt. So he kind of goes off to the side of the wadi, and you kind of watch him come back over and sort of like jab his foot in the ground. And you're like, well, what the hell is this kid doing? And then he goes off to the side again a little bit, and he comes back over and he sort of jabs his foot in the ground again. And you're like, what the hell is this kid up to? So at this point, the guys, so another little bit of the story is that the civilians who watch this PGIS are in a connex, essentially, directly across from the aid station.
They're on post.
They're in our cop. You open your doors and you walk out the front of the aid station, and then the connex for the civilians is a little bit off to the right. So they used to come over all the time whenever anything kind of interesting was happening on the PGIS screen. So they were like, hey, Doc, come check this out. So a bunch of us went over there and we were like watching this kid. And he's like, this kid has been doing this for like 10 minutes. So he'd do something, he'd step on it, he'd run back. So then we're watching him do this, and he walks over to the center of the bridge and just jumps. He like does a full-on jump stomp and initiates an IED.
Oh my God.
Yeah, so we come to find out that this kid had been paid by the Taliban to initiate an already implanted IED. He just walks over, takes this 9-volt battery, puts it in place, and then the kid, being a kid, was like, "Oh, I wonder if I can play with this thing." Or he went and he started, trying to initiate it, but not hurt himself.
Yeah.
And he ended up coming into our aid station. So they brought him in. We knew he was coming. Once it had happened, we had sent the word up to the talk, or the command, up to command, and they sent word out. The locals picked him up and brought him in, essentially. So he came to the aid station, and we treated him, and he was just like a lot of the other local nationals who we see who step on IEDs. They are triple amputation. They always have a relatively clean amputation on one leg, a pretty mangled amputation on the other, based on whatever foot they stepped on initially. Mm-hmm. So a lot of times we saw like a femur, one femur like spiking out, sort of, and then we would see one of the two arms, like usually their dominant arm would be pretty mangled or missing. So he was one of these cases. And a huge thing I took from training was that when we were training and we had this type of a patient, they were always unresponsive. And I don't know that I ever had an unresponsive triple amputation in Afghanistan. They were always very responsive, usually not responding the way you would expect a triple amputation to respond, and like very talkative. And you could usually gauge kind of how things were going based on how they were talking.
Sure. How high up were his amputations?
I would say probably, well, so he would have one below the knee.
And was that the one he stepped on the IED with?
I don't know, because he sort of did like a jump. He did like a jumping stomp. So I couldn't really tell you how. Yeah, like a kid would. I couldn't really tell you how he hit the actual plate or where the IED was in place from there. But then he would have an above the knee on the other. And then I don't really recall where his arm was.
Did it seem like they kind of cauterized? Was that why they would be conscious as opposed to just hemorrhaging?
No, a lot of times what we would see is that, like vasculature like retracts in an attempt to compensate for blood loss.
Yeah.
So your body is
the Black Hawk Down thing.
Yeah. So like your body is essentially trying to like close the container on its own, and then we call that compensation. And then shunting. And then when they it's kind of spiral, they lose the ability, and that's when they decompensate. So
and kids can compensate so well until they can't.
Yeah, that's a big thing with kids, is that they compensate like champs, but when they start decompensating, it happens quick. And he was one that he came to us very quickly. He was still very lucid, and we were able to get tourniquets on quick and evac quick. And he was even telling us that he was out picking berries with his mother, which, it's, well, like, no, we saw you, like, we watched you jump in that ID, like, we know what you're up to, like, there's no need to lie, like, we're still going to treat you, we're still going to send you away. Right. He was like, no, I was with my mother, we were picking berries. And he was very adamant about it. He was picking berries with his mother, and then he stepped in an ID. And that's kind of always what we saw. Like, there's always people came in, and when people came in and they stepped in IEDs, we didn't always have like a great like view on the PGIS of what had happened, or really even before the PGIS came there, we had like riot cams up in the corners, and we can kind of see some distance. We wouldn't ever actually know what the real story was. This was just a case that we did know what actually had happened. So it was always kind of the same. It's like people would come in, they would tell us that they were, innocently walking down a road and they
Right.
stepped on an IED or something. And it was always very similar, the injuries. Like, I think one reason why this kid sticks out to me is because he was, he was much younger. And we actually like watched it. We actually kind of saw it happen.
Wow. Did you guys have pediatric equipment with you?
Not initially. We got a Broslo bag, but I mean, there's a lot of leading up to that as well. Like we got there, and we had this wooden shack that they called an aid station, and and not to not be grateful for our wooden shack, because the unit before us got there, and it was just a marijuana field, and they kind of put up HESCO barriers and dug all the marijuana out, most of the marijuana out, I should say, and they created this from nothing. And then the one
Wow.
thing they did was they built a shack. So our aid station was kind of in the back of the motor pool. And as I said earlier, we were a striker brigade that was pretending to be light infantry for a while. So we had a lot of strikers, which are armored 8-wheeled vehicles, sort of just parked there. And then we had our aid station in the back. And for a little while, they were going to make our call sign Ratchet, but I was like, hey, that might be confusing for people because we're in the back of the aid station. So they might come for us to change their oil and stuff. So it was, built on nothing. So we didn't have a lot. We had what we brought. We had a few cases that got sent there. And then when our PA got there, he had brought some cases. But our resupply was very slow. We always sent up requests. And it was kind of one of the sort of funny, not funny moments when we actually started that big 16-man mass cal. Like that happened. And I think that was a sort of a jarring thing for our command, because they were like, oh my gosh, these guys actually need some resources.
Yeah.
And we had sent up like several requests for resources. And the thing that really pissed us off was that, we needed 4x4 gauze. So we used to send up on every request 4x4 gauze. And then we got this gigantic dump of medical supplies that we had requested, and it was literally all 4x4 gauze. They went through every request we ever made and only pulled out 4x4 gauze, and then sent us every last bit of 4x4 gauze. We're like, well, no, they were okay. So we had tons of 4x4, but we didn't have basic medical supplies, antibiotics and stuff. But we got very plussed up when they start to kind of see where our needs were, how combat heavy our region was. We got very plussed up. We actually built our own pharmacy room that we could lock, and we actually had a pretty good supply that we could choose from when actually treating both our soldiers and local nationals. So
wow, because in the civilian world, you never think about, oh, I need these supplies and I can't have them.
Yeah,
I mean, in EMS, you kind of did what was on the truck, but for the most part, you have 4x4s.
Yeah, and another thing with civilian medicine is you don't think of it in terms of triage necessarily. You start trying to triage patients based on your personnel, but also what do you actually have in your aid station that you can actually make a difference with.
Right.
So that comes into play a lot. And as your deployment progresses, that changes. Your triaging ability definitely changes. So you definitely make different decisions based on what you have available to you.
Yeah, when I was in whiskey school, they always did the mass cals, games and stuff, and they're always like, well, someone may be expectant and or about to pass away based on your resources. Sure, if you had a fully staffed Boston hospital, they would make it, but
totally.
Depending on where you are, they may not. So
yeah, and the other thing in training was we never do CPR in the field. No, we do. We actually quite the opposite. We actually had a rule that nobody dies in the aid station. If they're going to die, they're going to die in the bird. So we did lots and lots of CPR in our aid station. And having deployed and then coming back to garrison and actually having kind of focused on more courses, done ACLS and PALS and BLS. I had a lot of those I wish I knew this back then moments, things I would have done differently, things I would have requested differently. I don't know. It's just you kind of look at the different points or the different patients that you had and kind of what you did for that patient, and then you're like, oh, you know what I could have done in this case? Now that I know something a little better, I could have done this. Maybe I could have dropped that chest tube. And we had a hell of a time with this pair of brothers who were in our bazaar, who got into a fight. And this is the story, by the way. I don't know if this is actually true, but what the story was, the two brothers came in, one was unresponsive, both were stabbed. And the guy who could talk said that they got into a fight with a Taliban, some random Taliban, and he had stabbed them both. Mm-hmm. It was like a property dispute. He had stabbed them both and ran away. Okay. So one brother is unresponsive. The other brother, I'm trying to remember. I think he had some like posterior stab wounds. Like I think it like hit his shoulder blade. Like there was nothing too bad. I think we had addressed it occlusively, and then I don't think he had any like respiratory distress or anything like that. He was generally kind of okay.
Mhm.
His brother, on the other hand, had a hemothorax, and we were like losing him. He was, he was in an arrest, and we were doing CPR, and like the more we were doing CPR, the harder and harder it was to do CPR, and we were all like,
I got the tension.
yeah, we're like, what do we do? Like we're essentially in a wooden box in like the dirtiest place on earth with no way. We have no suction. What do we do? How do we keep this guy
Yeah.
alive? And it was basically like do CPR as best we can until the bird picks this guy up and hope that they have more supplies than we do. What else do you do? Do you just say, this guy's done? He's an Afghan. Let's not worry about him. Like,
Right.
no, you
How do you
do what
how
you
do you
can
sleep
do.
at night with that?
Exactly.
And you had nothing for a chest tube.
No, we could put a chest tube in. We were able
Right.
to do that, but we had no way to control output.
Right.
And so we had no suction. And then the other concern we had was like, well, if he's bleeding internally and we put a chest tube in,
He's just gonna extend
exactly.
it.
So like that back pressure is probably doing at least something to stop his bleeding. So if we can keep doing CPR, then maybe we can get him someplace that they can actually do something for him. And I can't imagine that he lived, but
at least you tried.
yeah, and that's all you can do. And I think that's kind of like the moral of the story when you're in Afghanistan.
I think that's the moral of the story, and a lot of times in emergency medicine is
Well, that's a good point.
yeah, like you just try until you can't anymore. So what was the story? The question I initially asked was, what was the story that prompted you to have books written about it?
Oh,
Where
okay.
You were,
Sorry.
Dr. Quinn.
So it's actually like a patient who they wrote about was like my very first patient in the field when I was a PFC.
Mm-hmm.
And I don't think I did anything wrong necessarily, but I was definitely like, shocked and trying to figure stuff out. Like a couple of things eluded me back then, like the venous oozing, because, when you're trying to stop bleeding, like you're going to get some oozing.
I would not want anyone to be writing about my early patients.
Yeah, because there's a learning curve, right?
There's a big learning curve.
So there was, this was in May. So this was a few months after we had deployed. So this actually, we must have left in April. My birthday is in May, early May. So I spent my 30th birthday. Like I said, I was older when I joined. I spent my 30th birthday on patrol in Afghanistan, like nearly passing out. Like it was horrible. It was like 130 degrees. You could like feel the heat coming off the ground. Shortly after that, we started fighting season. Fighting season started pretty early for us. We started getting sort of the lighter attacks a little bit earlier.
Okay.
And you saw them react to us as well. Like when we started doing something differently, they would start doing something differently. When we decided we were going to drive trucks around, they, started increasing the amount of HME that was in their IEDs. So homemade explosives that were in their IEDs. So we started seeing these larger bombs doing, more damage to our troops, but way more damage to our vehicles as well. Mm-hmm. So this one thing that was written about was my first patient. It was a day after my first contact. We were like at this very large element moving through like essentially the worst part of our AO, of our area of operation.
And contact is when you receive fire.
Yeah, so we received fire, and everybody fired back, even those of us who didn't know where the fire was coming from. They would call it out, and everyone kind of shot in the same direction. It was so far out. That's the thing. It was so far away. I remember thinking like, what are we aiming at? Like I know this is coming from over here, but like, are we aiming at something in particular? Yeah. The very next day, we had a mission that. So there's two bazaars. There was a bazaar that was right outside our COP, our outpost. And then there was another bazaar that they called the Taliban Bazaar. I don't know why they called it that. I just assumed it was because it was dangerous or something. So we had traveled to another outpost, which was being manned by just a platoon, that had the two medics. So we stopped there. We picked up an EOD contingency, and we sort of went on our way. And the idea was that we were supposed to find a weapons cache. So we dismounted. We walked very slowly because we had this EOD team with us. They were very thorough. They were like just hell bent on keeping us safe, which I definitely appreciate every single time it happened. Yeah. EOD was phenomenal overseas. Always came when we called them, no matter what time of day, no matter how many times we called them. And they always did a very thorough job, and I love those people. That being said, they stepped on a lot of IEDs, unfortunately. So this was the first time I had encountered that. We had moved to this bazaar. There's something called an ICOM, which I don't know what that stands for exactly. Insurgency communications? I don't know. One of the interpreters would hold a radio, and we would get ICOM chatter. So the enemy didn't have any sort of encoding on their communications. We could openly listen to them, and we'd have one of the interpreters just listen in and kind of hear what they're saying. So they're planning some sort of an attack on us while we were walking. We heard this. So we were expecting it the entire way. We came up to this bazaar, or we were expecting a bazaar, but it was completely empty. There's nobody there. It was a ghost town.
Yeah, it's a bad sign.
Yeah. So walking up to it, we're like, well, this is not good. So we ended up just kind of coming off the main road and walking around it because we thought that was probably a good idea. Now you're essentially walking into a kill box. So we walked up and around. We got to the other side of the bazaar, which is where the weapons cache was supposed to be. And, we set up our security area, and I kind of plopped down next to our platoon leader. We had some guys up on the road that were a little bit west of us, but there was like a main road that kind of cut through where we were. So we had a guy coming up on a motorcycle. Everybody overseas seems to have like a cell phone and a moped. A guy was coming up on his moped, and our security element stopped him, started talking to him. EOD was doing their thing, and there's suddenly this big blast, and then we hear gunfire. I don't know what's coming from what direction at this point in time, and I just start hearing medic. So I grab my bag, throw it on my back, and I start hauling ass over to where I see kind of the big puff of smoke. And you start just kind of running, and you don't really know where you're going. You're just kind of looking for people to direct you. And there were NCOs kind of pointing my way along the way. Yeah. And I just kept running until I found this guy sitting in a blast crater, this EOD team leader.
And you were the only medic there, right?
Yeah. So for every platoon element, there is typically one medic. They would do we'd have 3 days on, 3 days off, 3 days guard duty. So I would be on patrol for 3 days, and then I would be in the clinic for 6. That's kind of how it worked for medics. So I'm the only medic there. Now, we have trained some of these 11 Bravos, these infantrymen, to be combat lifesavers, or everyone has a skill to be a combat lifesaver. But the guys who kind of showed a propensity for medicine, we kind of picked out to be these advanced combat lifesavers. Sure. So I had a guy there who I think was a private or a PFC or something. So he was there with me. So it was he and I. This guy's team, the other EOD guys, had put some tourniquets on that weren't effective. So when I first came on the scene, they were still trying to kind of lash down these tourniquets. So I just started applying femoral pressure instantly. So you see this guy, he has an amputation below the knee, and then he has some kind of trauma to his other leg. I'm thinking it was left leg amputation. Oh, actually, no, it was left leg, seemingly partial amputation, right leg trauma. I wasn't really sure at the time. And then he had just had a little bit of trauma to his hand, nothing too bad, but I just remember seeing blood. So I was holding pressure on his femoral artery for his left leg while they were putting tourniquets on. And that kind of gave me a minute to kind of think about what was going on. Again, it was my first trauma ever. I'd only ever done this hypothetically with mannequins and stuff.
Yeah, there's a lot going through your mind. And
you are scared out of your mind. You were just like...
Not to mention you're being shot at.
So here's the thing is that we weren't being shot at. Oh, I don't know about the gunfire. Oh. I remember hearing it and running and thinking like, oh shit, here we go. Yeah. But that's the only memory I have of gunfire. I don't know who engaged who. I don't know if somebody saw us, like reacted to the blast and like shot some rounds off from like the distance. I don't really know what it was. It wasn't any of our guys, which is kind of strange. You would think that's would be the most likely scenario. Yeah. We have gone through it with a couple of guys before. We're like, we have no idea. I thought initially that guy in the moped was a VBED and a vehicle-borne explosive device, and there was some sort of a complex attack involved. That was not the case. So by the time I had gotten to this guy, his team had some tourniquets on. They weren't effective. I was holding pressure. I switched to just swapping out tourniquets, and that was my big thing. There's, the soft T tourniquet, the sort of newer, cool tourniquets. I was like all excited about. I had like a ton of them on my kit. These guys had a ton of them on their kits. They were throwing these soft Ts on, and I could not get them to stop the bleeding to save my life. And then I swapped everything out for CATs, for the combat application tourniquet.
Oh, so you had both of them on with you?
Yeah. So I had a different setup. I had a drop leg that had all of my tourniquets in it, and then I had my aid bag on my back. So I had all these soft Ts in my drop leg, and then I had a bunch of other stuff in my aid bag. So I pulled out my aid bag and I just started putting on these other tourniquets because they worked better. And I had set my kit up that way because I just had never used anything. So I didn't know really what was effective and what wasn't.
Yeah.
So in this case, after this event, I had taken all the soft teas like away from anywhere I could find. If I found one, I would just replace it with a cat. Even other people's aid bags. Like I'm just like, we're getting rid of all this shit.
I've never actually used the soft tea, but I have used cats, and they do work really well.
They do work, and they're one time, and if you move any tourniquet, you're gonna have to check it. You may have to replace it, but they work,
and you can adjust them really well.
Yeah, like that's why they're the staple. They've been a staple, and you would think that soft teas would work better. I just don't think they have the elasticity that cats do. I don't know exactly the reason why they don't seem to work as well. Maybe it's just user error, but they didn't work in this case. So I had reapplied all these tourniquets. We stopped the bleeding finally. We found out that his lower leg was really just skin. So we were trying to hide it from his view. But this is another case of a trauma patient who was completely lucid at the time. Like this, he was a staff sergeant. He was in the Air Force EOD. He was all business. He was like, no metal signature. Watch where you're stepping. No metal signature. And then we come to find out while we're doing this, and it's not even like a find out moment. It should have just assumed this while we were running towards it, that we just ran into like an uncleared minefield weapons cache. Like, this was the first area he walked into. So like, we don't know what's what, essentially.
Yeah.
I know I came from behind me. I don't know where the bird's going to get called to. Hopefully we're going to be good.
Right.
And this was the guy with the Valen,
Yeah, this was the bomb guy.
So 11 Bravos have Valens as well, but his big thing was there was no metal signature. He did not have a metal signature on the thing that he stepped on, which meant it was a more complex IED, which kind of meant they're like, hey, you're all in danger. So he was all business from the start. From the minute we got there, this guy, missing half of one leg, the other leg's all messed up.
So he's still giving these directions after the injury.
Yeah, after the injury, he's still like trying to make sure nobody else steps on an IED. He's like a badass. Completely stand-up guy. Yeah, he is a badass. He's still a badass, by the way. That's how the story ends. He's still a badass.
Good. That's a good ending.
Spoiler alert. So, but you can kind of tell, you can kind of gauge how he's doing, even his pain, based on how he's talking. He went from like, no metal signature, watch where you're stepping, this, that, and the other thing, very, very on business, and then slowly. And this, another part of the story, is the amount of time that had passed. Slowly, as time passes, he starts talking about his wife and kids. Then it's like, hey, if I don't make it, tell him this. Just tell my wife that I love her. Tell this, that, and the other thing. And so you can kind of gauge based on that dialogue that, hey, he's starting to feel pain. He's not doing well.
And I'm sure that adrenaline is coming down, that initial endorphin rush from the...
Yeah, totally. So, and we have morphine on board and the same thing. We have an IV initiated, and we're doing what we can do. Like I said, like it's all you can do. We had stopped the bleeding. And that's that point I had made earlier. Like, I didn't understand the idea that, hey, you stop arterial bleeding, but you're going to get venous oozing. So you're seeing blood come still slowly, but it's still coming. And you're like, hey, I haven't stopped this bleed yet. You know? And that's one of those things that you don't talk about in training. Only kind of experience kind of shows you that. And it makes sense. But at the time, you're like, well, what the hell? And it did dawn on me while I was doing it that that's actually what we had encountered here, that I should stop dicking around with these tourniquets. But at the same time, it's on your mind.
Well, you also feel like you need to be busy and doing something, I should be doing more when you're in kind of that trauma situation too.
And we have these statistics in our head that they talk about, like that's, massive extremity hemorrhage is the number one thing, that preventable injury.
Yeah, 70% of them can be saved. They like beat it into your head in the course. And
yeah, so I'm like, I need to stop this extremity hemorrhage. I have to. And, and it was stopped. And the more complex thing was the other leg. As you expose it, you see some peppering, you see a lot of trauma. I'm like, whoa, what's going on here? He had a spiral fracture is actually what happened. So
to the femur or tib fib or?
Tib fib. Actually, I don't know entirely how high up it went. I'm pretty sure it's tib fib. Pretty sure it's just tib fib. I'm trying to think, because I splinted above the knee, but I think it was just as precaution. So, you have a tourniquet on it anyways to stop the bleed. And then you SAM splint it. You do that. I cleaned his hand as well. I don't even remember his injury to his hand. And that's the funny thing. When I did the interview for this book, the guy who had written it, Brian, was like, yeah, so what was going on with his hand? And I was like, I don't remember his hand being injured at all. Did I treat his hand? He's like, well, I think so, because it had been bandaged and there was a lot of sand in it. I was like, oh, so I guess that must have happened when I was on the ground, but I don't remember. There's just so many traumas.
Yeah.
But I mean, his always stuck out to me because it was my first.
Yeah, of course.
So, we had splinted that leg. We had a tourniquet on to stop the bleeding. The other leg was tourniqueted. We, had kind of packed up the remaining appendage. It was still attached, but we didn't really want him to see it too much. So we kind of hid it from his view.
Right.
He had an IV in. He had morphine on board.
Did you guys have ketamine at this time?
No, and ketamine wasn't very widely used when I was overseas as like normal practice, but we used it based on my PA and our senior line medics experience. So we did have it eventually. We got it eventually, and we had used it for trauma patients, but not at this point. This was the first one that we had encountered.
This was like 2011, 2012, is that right?
Yep.
Because I think that's when ketamine started to get on the scene, because now it's super popular. It's great.
Yeah, we had a lot of conversations for like, does it have the same analgesic effect as morphine? And well, yes, studies show it does. And is it better for pediatric populations? Because we were seeing different applications for that as well. So it was something that had kind of been working into our repertoire.
Doesn't have the same cardiovascular effects, which is great for those traumas.
Yeah. You don't see as much respiratory depression and that sort of thing,
right?
Which would have been great to had known before I got there. But again, you kind of adjust fire as you learn stuff and whatnot. So we were using it, but we had started using it. The first time I actually remember it coming out was for like a really, really bad chai burn on a younger patient. But not for like regular trauma. My senior line medic had it. Our treatment NCO had it. I didn't have it in my aid bag. It just wasn't part of our loadout.
Yeah.
So for this guy, we only had morphine, and he's a big dude. Like this guy was a big guy. So I think I might have topped him up a couple of times because our wait time was really long. And he was the one that pointed out. The patient was the one that said like, "Hey, I don't hear a bird in the air yet." And I was like, "Well, shit, how much time has gone by?"
Yeah.
And this is a story that I tell every single time I go to or teach an Army EMS class when it comes to the MIST report.
Okay.
You're familiar with the MIST report?
Yes.
Okay. So we have our 9 lines that we call just to, get a medical evacuation apparatus in the air or to you in some way, shape, or form, which, consists of where you are, what type of patient you have, do you need extra stuff, what the area is like, all these different considerations. And then your MIST report is more specific to what's going on, like, your mechanism of injury, treatments, that sort of thing.
Yeah.
So in the case of this, it's that telephone. It's that you're relaying information to non-medical people who are relating information to non-medical people who are relaying information to non-medical people who are eventually relaying information to medical people. So at the time when I happened upon my patient, I had called it out as a bilateral amputation because just seeing the blood, seeing the one partial, and I made the assumption there were 2 partials. So that's what I called out.
Sure.
So our RTO called it up to our talk as a bilateral amputation, and they called it up to higher and so on and so forth. So higher got it as bilateral laceration.
Oh no.
And downgraded our flight.
Oh no.
Yeah. So there's all this radio chatter back and forth about it. And again, you're the medic on ground. You have no idea any of this is going on. You're just treating your patient.
Yeah.
So the patient brings up that, "Hey, I don't hear a bird in the air." And I call back, "Hey, what's the time on the bird?" And they're like, "Wait one." And then I never get a response. So eventually, randomly and without warning, a bird touches down on the ground. I'm like, "Oh, sweet. Okay." So
great, they're here.
Yeah. So we have them on this foxtrot litter, which is like a very small, it's like a miniature sked. It's awesome for carrying around. Can't speak highly enough of these things.
So
but
people that don't know, a sked, you explained that to me. A sked is like, it's rolled up really thick plastic that you can just slide everywhere. They're really fun if someone like pulls you around in them. They get really, really hot. It's like a really cheap like sled, like I don't know.
It's like a flexi sled. It's a sled that like bends, but it like wraps around you as well.
Sled for casualties, which is probably why they call it a sked.
Sked, yeah.
So yours is smaller.
This one was smaller, and I'd never experienced it. We just had them in the aid station, and we played with them, and I was like, "This is phenomenal because it's so much smaller."
Yeah, they're pretty big. The sked.
It doesn't have the sides that roll up.
Okay.
So it's just smaller. It was great. And this first patient we used it on was like a pretty big guy, like I said. So,
but he still fit on it.
And it's a 6-man lift, Okay. So we got 6 men, and we lifted him up, and we danced our way back through the minefield, and we got to this Black Hawk, and I did my best, fastest breakdown of my patient. I was like, "He had morphine at this time, and the tourniquets were at this time, and yada yada yada." Just rattling it off to this guy under the blades of this Black Hawk. He's just looking at me, and I get done, and he says, "Okay." he turns around and walks away, and I'm like, there's no way in hell he got that.
Yeah.
And I thought the exchange was so weird. I remember thinking like, how? I remember like having to like sort of like motion with my documentation again so that he took it.
Yeah.
Like he was just going to go. So he took my documentation and he left, and they flew away. And we work our way back to Hyena. Route Hyena goes through the Horn of Panjway. So my outpost was, you have the Arghandab come down into the Dory, and the Horn is essentially where they meet. So we're like kind of just around that area, and then like the Red Desert's south of that. So Hyena kind of drives to the point almost. So we're kind of just right off of that. We kind of get back to Route Hyena. And when I got back, I remember my battalion commander, who was like this super intimidating dude. He was like Captain America. This dude was just like, he was super intense, super intimidating.
Yeah.
And he pulls me. I was a private at the time. He was like, Private Hopkins, just want to say, we're really sorry about what happened out there. I'm like, yeah, okay, sir. It's not a problem. Like, like, he's like, we're really proud of you, what you did, and yada, yada, yada. And I had no idea what he was talking about.
Yeah.
Until I talked to our PA, who told me like all the radio chatter. He had hopped in our MEV, which we hadn't used yet, our medical evac vehicle. We hadn't actually driven anywhere. He and our treatment NCO and like some other group of Bravos went into security and just drove these strikers out there. We hadn't driven them anywhere. The route wasn't clear. They just drove, and they waited for me like at the closest point on Hyena, waiting for me to bring the patient. And I had no idea they were there,
Oh, wow.
There's like all this other drama going on because of this like messed up radio call. So then, flash forward a few years, when I'm out of Afghanistan, I'm out of Alaska, and I'm sitting in a bar in the Niagara County, New York area, talking to this guy who wrote this book. And he was like, hey, yeah, by the way, we tracked down what had happened, and some guys were doing a flyby in a Black Hawk and caught the radio chatter, like some non-medical personnel.
Ah.
They caught the radio chatter, and they decided that they were going to pick up your casualty. And they're the ones who stopped. And they weren't the PJs. They were just like some dudes. So I was like, well, that makes sense, because I rattled off all this medical stuff, and they were like,
Yeah, whatever.
okay.
Sounds good.
Yeah. And it's funny reading this book. You get some of the casualties' point of view about these privates that are in the back of this Black Hawk, and he like refers to them as robots. I'm like, well, they're probably mortified at this like mangled dude that's like not part of their mission,
Yeah, like, how did you get here?
Like they wouldn't know what to do anyway. So
Yeah. Oh my God.
that's craziness.
That's insane. So the guy's fine, the Air Force.
Yeah. So the Air Force guy, he's fine. He's doing well.
Fine, relatively. Yeah.
Yeah. I don't think it stayed below the knee. It's an above the knee amputation. He has a really good prosthetic. He is like a phenomenal dude. He's a firefighter now. We're friends on Facebook.
That's awesome.
Yeah. He reached out like very quickly after his injury, wanting to know some like very specific details. I've kind of kept up with him and stuff. He's like a power lifter. He does all these phenomenal things for like people with all of their appendages.
Yeah.
And just the fact that he does it with one less leg is just amazing. So he's living his dream of becoming a firefighter right now. So kudos to him.
Yeah, and that's so cool that you get to follow up with him.
Yeah, and he's one of very few. I have a couple of casualties that I have on Facebook, but I don't think some of them know that I was their medic in some cases.
That's a very interesting part of being a military medic that you don't get in civilian medicine. You don't follow people. I mean, I can follow people professionally in primary care, but in EMS, I didn't follow people. If I ever found out what happened to somebody, it was on the news that they died.
Yeah. And, it's kind of a rare thing even in military medicine, but it's based on were they your unit,
right?
And in this case, this guy wasn't. He was in the Air Force, but we had known a lot of the same people, and he had kind of sought me out. Some of the other people were like soldiers from my unit. So I think I was already friends on Facebook with them.
So are there any other stories you want to talk about? Anything about coming back to civilian medicine or...
So I don't know. It's not even coming back to civilian medicine for me. It was actually just coming to civilian medicine. I wasn't associated in any way with it. And I mean, I had a hard time with it initially because of, you come out of your deployment with a lot of fire and brimstone and, fire in your belly and wanting to do this stuff. And then you rank up and you start overseeing soldiers. After I'd gotten back and, I was, like I said, I was a private when I was deployed. I became a specialist while I was there. I got my 5 and became a sergeant, and I didn't really know what that meant at first. And I finally got the opportunity to kind of get some soldiers under me. And then that sort of led to this spot for the forward aid station for some field problems we had coming up. So I got the opportunity to actually be the NCOIC of this forward aid station and kind of learn it a little bit.
Mhm.
And then I just sort of like stayed there. I didn't leave this headquarters element. Our main NCO, this E7, left, and we didn't have a replacement for him. So I kind of took over those duties as well. So I became this like E5 who was in charge of these like 49 medics and doing all the stuff that was like way above my pay grade and like way above my knowledge base and
Yeah.
like my general like leadership ability. But
Adapt.
you kind of adapt and overcome, you do what you can. All of the officers that were involved in that process were like super understanding and like gave me a lot of leeway and like knew that I was on this like big learning curve, and they were really great. And when I was overstepping my bounds, sometimes they didn't necessarily fuck me down right away. So that was very kind of them, and I appreciate that. But coming out of that scenario where like suddenly like you're the NCO in charge of everybody, and now you're out of the military, and now you're in a civilian hospital, and you're literally at the lowest, like the entry level nursing position.
Yeah.
It's kind of a big culture shock. Like,
Yeah.
I was an advanced EMT. When you go through your military training, you come out of it being, back then it was EMTB, basic EMT. Now it's, I think, just EMT. And I wanted to get my paramedic before I left the military, but I didn't have enough time in service to go through the entire program. So I went with an advanced EMT.
Mm-hmm.
And then I moved to Massachusetts, where they don't really use advanced EMTs.
They don't recognize them.
Yeah, not at all. So I was working, as an entry-level nursing position, and I was learning all this cardiology stuff, and it was great. But at the same time, there's all these things you see in the hospital that are just normal functions of your day-to-day in the military, like putting in IVs, drawing blood, and that sort of thing. And, you really want to take the opportunity to show the things that you're good at.
Right.
And just because of your position, you don't, when you're in the military, you don't think about things like, legal liability and like, the things that hospitals worry about.
Yeah, you can't just go starting IVs all willy-nilly. But in the military, they're like, oh, sure, you want to learn? Here, go ahead. You can do it.
Yeah, like I remember like doing a dental block on an Afghan, a local national, because there was no other way that he would possibly get a tooth pulled. My PA was like, all right, well, put this dental block in and I'll pull the tooth. And I was like, are you serious, sir? And that's just what you do when you're overseas, because that's what has to happen. These people need some sort of treatment and they can't find it anywhere else.
Yeah, that would not happen in the civilian world.
It would not happen in the civilian world. Yeah, two different types of medicine.
I would not do a dental block, and I would not pull someone's teeth as a nurse practitioner.
It was a very strange situation because I had walked in on it. This is a completely different story, but this was that very clinical PA that I told you about. He was reading a book. There's a local national sitting on one of our trauma tables with another friend there and an interpreter as well. And he was reading. He was like, "Hey, look at this real quick. Read this. What do you read?" And we kind of talked about it a little bit. He's like, "Okay, great." And I was like, "Why are you reading this, sir?" He's like, "Well, I'm about to pull this guy's tooth. You want to help?" I was like, "Oh shit!" Like, yeah, okay. He was like, "All right, do you know where this location is? Can you find the landmark?" I was like, "Yeah, I think so." And then we did it. So it's interesting. It's an interesting thing, like doing everything and then coming to a situation that you really just can't. And it's a big part of that is understanding that you can't and why you can't. I fought it for a while. I was like, well, okay, well, if it's just like the name of my position, let's change the name of my position to something else. Like, I watch these RNs do like not great IVs or not great blood draws, or they struggle with it, and like,
yeah,
I do what I can to instruct, which isn't necessarily well received because not everyone knows your history or not everyone knows.
Oh, I can imagine that would be very not well received if they didn't know.
It's happened quite a bit. There's been nurses that have been like, we've had patients who are like in respiratory distress and they're like, he's in a lot of pain. Should I do morphine? And I'm like, no.
Yeah.
Maybe the CA shouldn't be the one telling you, no, you shouldn't push morphine on this person in respiratory distress.
Yeah.
But at the same time, there's another side of the coin. It's like you come from, this traumatic emergency medicine background and you don't necessarily know how things would function in a hospital setting. In certain emergencies we would send them to the hospital, which is where these people are already doing medicine. So
I ran into this issue when I was doing my undergrad in nursing. So I'm a nursing student. You were the lowest of the low again.
Mm-hmm.
And I had done 10 years doing 911 EMS, and people were like, you have no idea what you're talking about. And I was like, well, no. Nursing instructors who had done something where they didn't do anything like trauma or stabbings, or they had no idea. And I'm like, well, you would do this and you do that. And they're like, you're a know-it-all, shut your mouth. So I get it. It's hard. It's very frustrating. You want to go to the level you were at and then keep going, not take a step back and be taken it from someone that's kind of being rude.
Yeah, I mean, there's two factors. There's your pride,
Yep.
which you need to not be
Yeah.
a factor, essentially, and then there's like
Yeah.
patient safety. And like I will always speak up when it comes to patient safety, and it's something you just have to accept. Like maybe I won't make a snide remark when I see somebody doing something not 100% right, but isn't detrimental to a patient or patient safety.
It must be a little comforting having worked in pediatric critical care before having a child.
You know what? I think it helped for sure, especially like being not only just working in pediatrics, but also just like being a CA in pediatrics,
Yeah.
changing lots of diapers, comforting lots of babies. I think that definitely helped my own baby. So that definitely just heard mommy say, "Daddy's busy."
Can you say podcasting?
So, can you hear her?
Cameo appearance. Yeah. That's cute.
Yeah, I think sometimes I talk about this big difference between the military side and the civilian side. And it's just based on my experience is that when you're in the military, when you're a medic with the infantry, you kind of need to keep a certain professional distance. And it's hard because like these are the guys who you live with, they're your friends.
Hmm.
And in my own experience, I would keep my platoon arm's length sometimes just because they were the guys who, if I was out and about, I was going to have to treat.
Right.
And emotions definitely, they're a factor when you have to treat somebody,
Yeah.
like you need to think clearly and you can't be kind of overcome. That being said, like you kind of like recede into your medics and, they're your family that you kind of emote with more than anyone else.
Yeah.
And then they get injured and then you like I remember this. We had this one. It's actually the same incident where that triple amp I told you about earlier had happened, but we had a medic get hit on one of our ops, and I wasn't part of my platoon anymore. I had the medic who delayed his deployment because he was having a kid got to country, and he took over that spot, and I kind of went back to my old spot in fourth platoon. So I was in the Fister Vic, which the vehicle for the guys who call in different things. The element that was patrolling took contact. It was this operation that was kind of joint with this engineering, the sapper unit. They were launching what they called APOPs. They shoot a rocket forward with a chain with det cord on it, and
Oh yeah.
they launch it forward on a path, and then they do a sensitivity det for like any IEDs that are along a path. They went on this operation, and they just did that down a path. So our element was just pulling security for them. So our first platoon element was pulling security for them, and the medic in this element was actually like one of the younger medics.
The one that had a kid.
No, this is a different medic.
Okay.
The guy who had a kid just took me out of my spot, but that wasn't the element that was out. This was the first platoon.
Okay.
So they were doing their thing. He was out there, with his guys, and they took some contact. And I'm a little unclear as to what exactly it was that hit them, but some sort of larger caliber something had passed between his legs, and it caused some trauma to his thigh. He wasn't shot necessarily, but he had a big chunk of his thigh that was missing.
Mm-hmm.
So, I remember being in the vehicle, and they had called his battle roster number.
Mm-hmm.
In this case, it was like CL something. And, I remember sitting there thinking like, CL, who is that? Like, who's CL? And then the only person I could think of was one of my medics, not my medics, but like one of my fellow medics.
Right.
So I like hopped out of the truck, and I like sprinted across this CP that we had set up that was not really cleared, but I didn't really think about that.
Collection point.
Command point.
Command point.
In this case. So like we had all of our strikers were out, and then in the center of that was, the commander's vehicles and stuff, and the command vehicles. So they fell back to the commander's vehicles, and they called in the 9 line from there. So we had like this medic, and then one of the Afghan police guys was hit. So, all of the medics kind of converged in this point, and like we were all really focusing on this one medic that was hit. And he's okay, like he was fine, but we tourniqueted the shit out of him, and dressed his wound and stuff like that. We took care of the ANCAP guy as well, but like we definitely responded more emotionally because that was like, hey, that's one of our own.
Yeah, of course.
And that's the whole reason why you like, you kind of keep certain people at arm's length while you're overseas. Now that being said, you take that mentality as a medic and you translate that to pediatric cardiology. You need to relate to these kids. You need to get them to trust you. You can't really keep them at arm's length emotionally. They relate to you more doing the opposite by like you kind of being emotional with them and like kind of connecting with them in that regard. So that was a huge takeaway, a huge difference for me from the civilian side to the military side. Was like a lot of these kids, and inpatient especially, like I built a relationship with because I needed them to trust me for me to do my job.
Well, thank you for letting me take up so much of your Saturday night.
Oh yeah, nope, not a problem at all. Not a problem at all. Thank you for having me. This has been a nice conversation.
So, before we go, you're actually a singer songwriter and you made the podcast amazing custom intro music that we heard at the beginning of the episode. And I'm going to be playing one of your original songs at the end of the episode. Do you want to plug your social media and YouTube?
I do have a music YouTube channel. I have so few followers that I don't even have a easy short YouTube name, but www.petesingthings.com, because I am Pete and I occasionally sing things and then post them on the internet. You can follow that address will get you there. So yeah, I did a bunch of videos last year because I was trying out for The Voice at the urging of my sister-in-law, and it was like super fun. I used to play music when I was a lot younger. I kind of stopped because I was like in the military and stuff. I just kind of got back into it. It was a lot of fun. So I think I'm going to actually start doing it again really soon. Yeah, PeteSingsThings.com. And yeah, thank you for having me. I appreciate it. It's been a lot of fun.
Thank you for being here. And if anyone wants to listen to more episodes, they can subscribe, always give us some ratings or reviews, and follow us on social media. Facebook and Instagram are Antidotes Podcast. Twitter is Antidotes Pod. My Twitter is Christine the NP. And I will see you all next week. Bye.
Bye-bye.
In the land of sand and stone, it's bittersweet the way comes rushing back to me in these places that I go. And maybe I'll tell you someday, maybe I'll show you how much I love you and how much I care, how much I